Men also have cancers that are hormonally driven. 1 out of every 5 men will develop prostate cancer at some point in their lifetime, and the number one risk factor for developing prostate cancer is advancing age. As much as 75% of men with this type of cancer are over the age of 65. However, if a younger man does get prostate cancer, it is usually one of the more aggressive types. Although prostate cancer is the second most common cancer for men, if it is found early, it has nearly a 100% cure rate. The digital rectal exams and the PSA testing is attributed to decreasing the death rates for prostate cancer by approximately 4% each year from 2001. So early detection is key, and the earlier prostate cancer is detected, the better chance there is for treatments to be effective. Prostate cancer is mostly androgen-driven, which is a male hormone, and specifically testosterone-driven. It is a glandular cancer that is called an adenocarcinoma, and it is characterized by a slow and predictable spread. And the way it does spread is by direct invasion to nearby organs or by the bloodstream to nearby bone structures such as the pelvic, femur head, lower lumbar spine, but also it can spread to the liver and lungs. It can also spread by lymph nodes, but not to the degree that breast cancer spreads. Risk factors include age, ethnicity, and family history of prostate cancer, but also having had a vasectomy, a diet high in animal fats and low in fruits and vegetables. African American men also have a higher incidence of aggressive tumors at the time of diagnosis with higher death rates, which is likely due to men not wanting to do the screening test. The best screening tool is the digital rectal exam, where the practitioner feels for hard nodules or irregular borders of the prostate. The PSA, or prostate-specific antigen, is a protein made by the prostate that plays an important role in fertility. The level varies by age and sexual activity, but in general is elevated with prostate cancer. A normal PSA level for a man who is less than 50 years old is less than 2.5, but a normal PSA for a man greater than 50 years old should be less than 4.0. It is also elevated after a digital rectal exam, so if doing both screening tests, the PSA should be drawn prior to the digital rectal exam. Prostate cancer usually causes no symptoms in the early stages, and most of the time it is first detected by a doctor doing a routine checkup. As the malignancy spreads, it can constrict the urethra and cause urinary problems similar to those of BPH, which is benign prostatic hypertrophy. Urinary symptoms are frequency, urgency, hesitation, burning, nocturia, and possibly hematuria. Changes in sexual function might also indicate the presence of prostate cancer. Late-stage symptoms could include gross hematuria, but more significantly, if metastasis has occurred, the man will likely experience a chronic pain in the spine, pelvis, hips, or upper legs, signifying the cancer has spread to these bones. Diagnostic studies include a transrectal ultrasound to look for abnormalities. Transvaginal ultrasounds are also done to assess for things that should and shouldn't be there. A definitive test is to biopsy the abnormal cells, and if metastasis is suspected, a bone scan with radioactive nucleotide will be done in conjunction with a CT or an MRI. This prostasync scan uses a process where radioactive antibodies are injected into the body that will bind with prostate antigens. The scan will show as hotspots if the binding does occur, and then that signals to the practitioner a site or lymph node that needs to be further assessed. Treatments for prostate cancer range from watchful waiting to a variety of other treatments. If a man's life expectancy is less than 10 years or there are multiple comorbidities and a low-grade, low-stage tumor, watchful waiting is one of the options. They say that many men live and die with prostate cancer, but not from it. If a more aggressive treatment is needed, the prostate and other surrounding male anatomy will be removed, which may include the seminal vesicles, portion of the bladder, neck, and more. They try to spare nerves needed for erection, but often sexual performance and urinary continence can be affected. A simple prostatectomy, which could be used with earlier staging, is called a TURP, transurethral resectioning of the prostate. This is where the surgeon goes in through the penis and removes a portion or as much of the prostate as they can. Other adjuvant therapies include cryotherapy to freeze and destroy the cancer cells, radiation, which could be either brachytherapy or external. Chemotherapy has a poor response to this type of cancer and is generally only used for palliative purposes in advanced staging. Hormonal therapies are all to reduce the androgen, testosterone-driven cancer. It can be accomplished by giving hormone blockers or with an orchiectomy to remove both testicles. The orchiectomy removes about 95% of the testosterone. Hormone manipulation always has many negative side effects, and for a man, they may experience hot flashes, erectile dysfunction, loss of sexual desire, irritability, weight gain, loss of muscle mass, and osteoporosis. Standard post-op care always includes bladder irrigation to remove clots with strict INOs, assessment and care of surgical wounds and incisions, medications and labs, pain management, early ambulation with TEDs and SCDs, DVT prophylaxis, incentive spirometry or turn, cough, and deep breathe to prevent pneumonia, stool softeners. Most of that is with every surgery. Discharge teaching would include 4 to 8 weeks with no lifting or strenuous activity and no sexual intercourse for 6 weeks, and follow up with PSA testing. Going to change gears now and talk about testicular cancer, which accounts for only or less than 1% of all male cancers. It commonly affects males ages 20 to 35 years old, and white males, Euro-Americans, are 4 times more likely to be affected. It occurs in the right testicle more often, and it has a 95% cure rate with early detection. The cancer cells are either from sperm-producing cells or testosterone-producing cells. Risk factors include an undescended testes, which is called cryptorchidism, orchitis, or chronic inflammation of the testes, family history, mother's use of DES, and HIV. The most common symptoms include the classic sign of a painless lump in the scrotum, scrotal swelling, feelings of heaviness, dull ache in the lower abdomen or perianal area, testicular pain or lymph node swelling. Metastatic symptoms could include back pain because it goes to the bone, cough, dyspnea, hemoptysis, dysphagia, gynecomastia, or a sudden hydrocele. So men are encouraged to do the testicular self-exam, which are best done in the shower because warmer water makes the testes hang lower in the scrotum, so then they're easier to palpate. You check one testicle at a time by rolling the testis between the thumb and the first 3 fingers. Choose a consistent day of the month, and if a firm mass is palpated, contact the healthcare provider. Diagnosis is done by palpation, ultrasound, the blood studies, chest x-ray, and CT scans. The blood study includes the alpha-fetal protein and the human chorionic gonadotropin, which are both tumor markers for testicular cancer. Treatments include an orchiectomy and systemic chemotherapy, which is very effective against the germ or sperm cell tumors. Killing the cells that make the sperm will lead to sterility, so instructions need to be given about the possibility of saving and freezing the sperm for later use. It's important for all patients, no matter how early the cancer is detected or treated, to have regular and careful follow-up exams, including chest x-ray, CT scans, and the blood study exams. The nursing diagnoses for the male cancers include urinary incontinence, risk for infection, sexual dysfunction, sterility, disturbed body image, and acute or chronic pain.